this is a case report discussing like intraoperative placement during a C-section. Of course, this information is completely based on my clinical experience. And I think it's also important to note that, we use all the tools in our toolbox. I think I speak for Dr. O'Daniel and myself in saying that we want every tool available to us to control bleeding and protect patients and improve outcomes. And so we'll be reviewing some specific cases regarding JADA placement, but recognize that, we use the entire set of tools at our disposal at all times. So this particular patient is a 27-year-old G3P0020 at 39 weeks and 1 day's gestation. And her history was significant for having 2 DNCs previously for missed ABs, both of which had very significant hemorrhage involved, so much so that she was sent to hematology for a full workup to investigate what may be causing that, and her workup was negative. And so now she is pregnant and term and had a baby in which fetal macrosomia was suspected. In reviewing her options, she requested to proceed with a primary C-section. And so prior to her case, as we were prepping for her case, of course, we had plans to be as prepared as possible, knowing her history. So all of our pharmacologic agents, our mechanical uterotonics, specifically the JADA device, and everything in our hemorrhage cart was already on standby. We had blood that was cross-matched and in the room and on standby for her as well, and a extensive team huddle as to all the roles that would be needed and how we would move through JADA placement if it was warranted. Once delivery took place. So she had her epidural anesthesia. We discussed with anesthesia that upon uterine incision that an antifibrinolytic would be given. So they were given that order in advance. So she underwent delivery of her infant, which weighed 9 pounds. And again, at that uterine incision, the antifibrinolytic was given, and then our standard oxytocin IV bolus, of course, was initiated. And then the placenta was delivered. And at delivery of the placenta, she had uterine atony and abnormal bleeding was noted at that time. She then was given a dose of Methergin IM, and I gave an additional dose of oxytocin IM directly into the uterus while we were closing the hysterotomy. As the hysterotomy was being closed, the uterine atony persisted, and the postpartum hemorrhage point was reached at a liter of blood loss, and she was given a dose of Hemabate IM while we were readying the device for placement. So as the remaining portions of the uterus were being closed, I ordered a unit of packed red cells to begin transfusion, and the staff started readying the device, getting the tubing connected, getting the syringes filled, and getting everything ready so that as soon as the hysterotomy was officially closed, we could then move forward with JADA placement. So at the time the device was inserted, we were at 1900 mLs of QBL. Just like I described previously, we went below frog-legged, evacuated clot material, placed the device, connected it to vacuum after the seal was filled, and in 2 minutes, the uterine tone was significantly improved and the bleeding was controlled. In that 2-minute time frame, there was still some brisk bleeding. So there was 250 mLs in the canister at that 2-minute mark when bleeding was then controlled in this sense that the uterus itself was firm and the bleeding that was moving through the tubing at that point was moving very slowly. So once I felt comfortable that the bleeding was controlled, then we taped the device to the patient's inner thigh, just like we do, and then repositioned the patient. I then went and broke the scrub that I was in, re-scrubbed, and continued the case. So at that point, the second layer of the uterus was closed, and then the rest of the C-section was completed. And at the completion of her case, 50 minutes or so after bleeding was controlled, the QBL for the procedure was 2440 mLs. So the device was left on to suction for 2.5 hours. This was somebody whose uterus didn't respond very effectively to the medications we were giving and did respond very well to the JADA. So for my own just random clinical decision making in this scenario, I kept that vacuum on for 2.5 hours. I find that the longer we've used the device, the more comfortable we feel that 1 hour is plenty adequate in almost all cases for controlling bleeding. But this particular case, we did keep that vacuum on for 2.5 hours, and then had them monitor her uterus for an hour prior to removal of the device. And so she had a total indwelling time of 3.5 hours. And when they removed the device, she had 150 mLs of additional blood in the canister that happened over that recovery timeline. So in review, the device did work quickly. It did work effectively in minimizing the bleeding from the time of placement and on, in a patient that was expected to bleed and was also given a fair number of pharmacologic agents prior to device placement. So we did attempt to control her atony first pharmacologically before we recognized that we were moving forward and quickly into a hemorrhage situation, at which time we used the device. And so she did not require any additional blood products past the 1 unit that was given in the OR. She was breastfeeding well and was discharged on postpartum day 3 with an otherwise postpartum course. And so, we were prepared. We had everything at our disposal. We had a plan for how we were going to move forward, and we were moving very efficiently in treating this patient. And despite even moving efficiently, she had a very significant amount of blood loss. So being able to use the device in a timely fashion, knowing that it provides very good control, I really feel like prevented her from having a poor outcome and, from further blood loss.